So thank you to everybody for joining us today. I see that there's a lot of folks online, and I don't want to spend too much time talking about what happened last year. I want to spend a lot of time talking about how we prevent this kind of catastrophic event from happening again. And that's really Dr. Kenny and Dr. Robert Meade who are going to help us understand, what we need to do and where we need to go. But I still do want to set the scene. Today is the 1-year anniversary of the day on which the highest number of people died in 2021. And as we're having this conversation today, I just encourage everyone to remember at this time of last year, hundreds of vulnerable people died because it was so hot in British Columbia. This is climate change related event. It's going to happen again in Canada, and we have significant work to do to ensure that these events in future do not have the same type of impact as this one did in 2021. Before I get into that event, I just want to make a little bit of a plug for this new tool from the NCCEH, co-developed with Dr. Kenny's lab. This is really to recognize that doing checks on susceptible people during extreme hot weather is one of the many ways that we can help to keep them safe, and to recognize that people who do those checks may not have really good training in heat-related illness and susceptibility and intervention. So this is a 5-page tool that we've put together to help anyone who is doing health checks during extreme hot weather. And I'll ask one of my NCCEH colleagues to pop the link to this new tool in the chat with the hopes that it can be helpful to you or to others. So at this time last year, we experienced one of the most intense heat events on the face of the planet ever recorded with respect to differences in the temperatures that we were experiencing from what we would expect at that time of year. This is an image from the 27th of June. It got even hotter on the 28th and the 29th. Overall, we experienced temperatures that were 15 to 25 degrees hotter than is normal. I really like this image because it shows how BC specific this event was. Certainly the heat spilled out into other places, but this was really a British Columbia heat dome, and the degree of anomaly experienced in British Columbia was far higher than the degree of anomaly experienced in other places. There were hundreds of deaths during this event. What I'm going to talk to you about right now is a concept called excess mortality. There's a pretty regular number of people who die in British Columbia on a day-by-day basis. That's the green bars that you see at the bottom of here. It's about 110 people per day with a standard deviation of about 20. Because that's so consistent, we can relatively easily model with statistical models how many people we expect to die over a given period. And then we can look at the difference between how many people actually died and how many people we expected to die. And we call that difference the excess mortality. So this isn't a precise measurement of how many people died, but statistically it gives us some indication of the degree of impact. So we had 8 days across BC where there was a statistically significant difference between the number of people who actually died and the number of people that we expected to die. And I'm calling this the period of the significant heat dome impact. You can see in the early part of the heat dome, the effect was quite small. And then as it started to get hotter and hotter and hotter, these deaths started to increase and increase and increase again. This is June 29th of last year, where we had hundreds of excess deaths in one day. And then the deaths continue even after the temperatures start to go down. And that's quite consistent with a typical heat dome or extreme heat event. Now, the number of excess deaths is somewhat different from the number of deaths that the coroners have attributed to extreme hot weather, and I just want to walk you through that so that you understand the differences. The coroners put out a letter at the beginning of the heat dome to all physicians saying, if you believe you have a death that may have been heat related, please report it to us. That increased the number of deaths reported to coroners to about 54% of all deaths in this hottest week, compared with about 30% in a normal week. So the coroners can only attribute a death to extreme hot weather if they investigate it. That means that 46% of deaths that week never even had the opportunity to be attributed to extreme heat because they were not reported to the coroner service. So the coroners have, to their credit, been able to attribute hundreds of these deaths to the extreme hot weather, but we still expect that there were deaths due to the extreme hot weather that have not been correctly attributed. And that's why you see this difference between 740 excess deaths and about 600 deaths attributed by the coroners. One of the most important things is the distribution of these deaths within the population. There's often the misperception that the most elderly are at highest risk. Certainly there were, in terms of absolute numbers, that's where we saw the greatest number of deaths, but you have to remember that's where we would see the greatest number of deaths on any given day. We also saw deaths in really all age groups over 50. And when we look at the proportional difference between what was expected and what was observed, we see there's almost a doubling of deaths in all of these age groups. So in absolute numbers, yes, it is the most elderly, but when we look across all older adults, we see a pretty uniform type of effect. Also, we have to look at where people died. So there was certainly some deaths in acute care, about a 25% increase, some deaths in residential or long-term care facilities, about a 25% increase. But the real story here is that most of these deaths happened in the community. They did not happen in care settings. They happened in private residencies. And this is perfectly consistent with what the coroners have found and reported in their investigation. So in this hottest week, from July 25th, or from June 25th to July 1st, they have attributed 526 deaths to the heat. And when I say attributed to the heat, that means they have concluded the death would not have occurred if it had not been very hot. Of these 526 deaths, 506 were in private residencies. And the reason this happens, if you've heard me speak on this topic before, I'm sorry, because I'm going to repeat what I say every single time, but it is so important. People do not die because it's hot outside. They die because it is hot inside. These are data from Abbotsford. The black line is Abbotsford International Airport. The blue line is a home in Abbotsford with central air conditioning, and the red line is a home in Abbotsford without central air conditioning. So here you can see this heat dome start to build. We're getting to temperatures in the mid-40s. That doesn't have any impact whatsoever on this home with air conditioning. These are safe indoor temperatures. Anybody who lives in a building like this is protected. In the home without air conditioning, we certainly see it was warmer before the heat dome than the home with air conditioning. And then these day over day increases in outdoor temperatures translate to day over day increases in indoor temperatures, to the point where at the hottest part of the heat dome, it is 40 degrees inside of this house. Also note that this peak is happening a couple of hours after this peak, which is usually going to be 5 or 6 p.m. at this time of year. So, you know, it's hottest when people are starting to think about going to bed. It's important to note that this event occurred just after the summer solstice, so we have huge daylight hours and huge solar heat gain into people's homes through their windows. I'm sure Glen's going to talk about this a lot more, but you know, when we're talking about safe indoor temperatures, I've drawn a box on here in orange. Indoor temperatures under 26 degrees are generally safe for everyone. Risk does start to increase at sustained temperatures over 26 degrees for the most susceptible. And then for susceptible populations, if you're looking at sustained temperatures over 31 for hours and days, you've got a problem on your hands. Well, if there was a susceptible person in this home, they definitely would have a problem on their hands. Finally, I want to point out that again, I think there's this misperception that a house will normalize to the overnight temperature, and it does not do that. So here, we're up around 42 degrees. The temperature drops down overnight to about 24 degrees, a very high overnight temperature for the region, but a safe temperature from a human health perspective. This house does not do that. It only comes down to about 32 or 33 degrees before it starts to climb back up again the next day. Finally, I want to point out that the deaths during the heat dome did not stop after the heat dome, or the deaths caused by the heat dome did not stop after the heat dome. Coming back to this idea of excess mortality, this is cumulative excess mortality over all of 2021. Now, in a normal year, we'd expect this to be pretty flat throughout the year because this is the COVID pandemic and there's a lot of stuff going on. We are accumulating excess mortality in most age groups. If we look at this 60 to 79-year-old age group, you can see it's kind of going up and up and up. The heat dome hits, there's a big jump. If we'd followed the pre-heat dome trajectory, it would have gone like this dashed purple line here. After the heat dome, it goes like this. These lines aren't quite parallel, so a little bit of impact maybe of the heat dome, but there's also a bit of a shift in the COVID situation after the heat dome as well. If we look at the other hand at those 80 plus, what we see is pretty flat coming into the heat dome. Indeed, there's the trajectory if we had continued the prior trend, big jump at the heat dome, and then it goes up and up and up and up. So very likely that these temperatures also caused injuries that made people, especially very older people, susceptible to death in the weeks and months that followed. We've done 2 big studies so far on the health effects of the heat dome, one looking at community factors in the Greater Vancouver region associated with death during this period, and one looking at comorbidities associated with death during this period. I do not have time to go into all the details. This study has been published. If you're interested in reading it, the link is here. In brief, what we found is that neighborhood material and social deprivation matter. So when we're comparing neighborhoods to those with normal material and social deprivation, we find that there's no effect in the privileged neighborhoods whatsoever. If we're looking at a socially deprived but materially privileged neighborhood, there is an effect. It's not statistically significant, but still a 50% increase in risk. Materially deprived but socially privileged, 100% increase in risk. And when we're looking at both elements of deprivation, a 200% increase in risk. The only good news story here is that tree canopy is associated with a reduction in risk. So a 5% increase in tree canopy associated with a 10% decrease in risk, adjusted for deprivation. So even in those highly deprived neighborhoods, tree canopy matters. It has protective effects. When we look at the comorbidities associated with death, we are considering potentially heat-related deaths, so those deaths that are under investigation by the coroners, versus non-heat-related deaths, those deaths that happen during the heat dome that have been assigned a cause of death that has nothing to do with heat. And what we see is by far what stands out is schizophrenia as a risk factor, and it is a risk factor in both cases, in both of these types of deaths. We also see depression and substance use disorder among the potentially heat-related deaths, diabetes among both groups, asthma among the non-heat related deaths. Again, not surprising, we had very high ozone throughout the Greater Vancouver region during this period. On the other hand, we see a bunch of things that are not associated with risk. They're associated with lower risk during the heat dome, and chief amongst them is dementia. We would hypothesize here that people look out for people who have dementia. They take special care of them when there's climatic conditions like these, and therefore they are likely protected during these events, if not after these events, as I showed in the previous couple of slides. So I just want to end by saying, I hope this paints a pretty stark picture for you of who was at risk during this heat dome. The risk factors are indoor heat for sure, mental illness, social isolation, substance use disorder, deprivation, diabetes. Protective factors, indoor cooling, privilege, green space, social connection, and being cared for. And at this point, I want to hand it over to our colleagues to talk to us more about what we can do to prevent these kinds of effects from happening again. Thank you.
All right. So I guess I will now take the stage. Thanks so much, Dr. Henderson, for setting the stage for this, for my presentation. So let me just transfer over here. So we'll share my screen here. And hopefully everybody will see this in 1 second. Just give me 1 second here. All right, so everybody should see the presentation now. I believe, Sarah, you can see the main page. Excellent. All right, so thank you very much, Sarah and colleagues, for this invitation to speak to you today. So I'm going to be talking about overheating in the home and what is a safe indoor temperature limit. I think this is a timely and important question in view of what happened last year. So to ensure that we're all sort of on the same page, one of the things that we want to talk about is really what is the human heat stress response. I want to make sure everybody's on the same page and that we're all understanding the same factors here. So heat strain is the overall physiological response resulting from exposure to a heat stress. And factors that will affect that will be, again, that will contribute to heat stress will be high ambient temperatures, radiant heat sources, high humidity, and physical activity. So people are more active around the house. That's certainly going to cause a greater amount of heat strain in the individual. So elevated levels of heat strain can lead to heat-related injuries or death because an individual may not have that capacity to dissipate heat. So what you're looking at on the left here is that heat stress, heat strain response. And you can see some of these important factors. Some of these Dr. Henderson talked about, certainly sex and age plays a role. And certainly, as the BC Coroner's report indicated, chronic disease is an important determinant as it related to these heat-related deaths. We also know that there are a number of individual factors that can certainly exacerbate these responses, and that is change in hydration, exposure duration, whether a person is sedentary or physically active. So these are critical factors that can affect how much heat a person can lose for a given level of heat stress. So one of the things I want to look at here on the right is really what happens in a hot environment. So imagine you're in this hot indoor temperature environment. You're gaining heat from the sun and indoors. It's warming up the air. All of the objects inside are getting warmer. Essentially, any warmer objects in the evening, certainly during the day, will radiate back to the individual. So there's very limited capacity to dissipate heat. The environment is warm. So in this situation, for this individual, the primary avenue of heat loss is going to be the evaporation of sweat. So if we can imagine that age and chronic disease limits that capacity, you can understand that for a given level of heat stress, why perhaps an older person or a person with chronic health conditions may be at greater risk of a heat-related injury. All right, so before we move forward anymore, I do also want to show to you exactly what's happening in terms of whole body heat exchange in an older person during an extreme heat event. So I want you right now, as you're sitting in your office or at home, your nice cool environment, it's nicely air conditioned, and you saw from Dr. Henderson's figure that you're around 22 degrees Celsius. So that's nice and cool. Now I want you to walk into that hot day that you experienced perhaps in BC. And what you're going to see immediately upon entry is the body's going to warm very quickly, because as you can see here, the body's going to gain heat very rapidly. It's cooler, it's absorbing some of that heat, it's gaining some of that heat. And eventually what you're seeing is the rate of heat loss slowly rising up in this young individual. Eventually there's going to be a point at which the rate of heat gain is matched by the rate of heat loss. At that point, body got hotter. So core temperature goes up, but now it's stable at the end of this 3-hour exposure. Now let's migrate to the older adult. Remember, we said that older adults may have a limited ability to dissipate heat. And we saw in the BC Coroner's report that older adults, 50 and above, were certainly more vulnerable. Our work has definitely showed that they have limited ability to dissipate heat. And that, as we get older, increases as that impairment becomes greater as we get older. So one thing we see in the older adults is, as they're gaining heat from the body, they're trying to increase that heat loss, but you can see towards the end, they're not achieving heat balance because heat gain is not matched by heat loss. So as a result, at the end, they've got this rapid increase, and now core temperature is rising ever so slightly. Now, if we look at the person with type 2 diabetes, you're seeing that essentially the same numbers, 347, 344. What does that mean? It just simply means that they're storing the same amount of heat. It's certainly more than the 204, about 1.7 times more heat. Now, you would say in this case here, well, there's nothing different between the older and the older type 2. The key difference is that, yes, they're storing the same amount of heat, they'll have the same core temperature, but the pathway to hyperthermia is different because the rate of heat gain for the patient with type 2 diabetes is higher. So higher rate of heat gain, they got to push it even higher. So essentially, the primary avenue of heat loss will be sweating. So they've really got to increase that sweat output. So while they may have the same core temperature, the pathway to hyperthermia is going to be slightly different. All right, one thing we also have to consider, let's look at that BC Coroner's report. Throughout that report, there's a lot of mention about air temperature. Surprisingly, limited information about what humidity was. I think that's a critical factor because what I just said at the very start is that humidity matters. Why? Because in an overheated home, the primary avenue of heat dissipation will be the evaporation of sweat. However, if you have many occupants in the home, it can get humid. If people are using showers and what have you, the room can get humid. That can raise humidity. What we do know from our own work is when we compare young and older adults exposed to this 2-hour extreme heat condition, you'll see that both young and older will store almost 2 times more heat. This is important because that pushes that stress level even higher. So it challenges it puts this individual, the older individual especially, at higher risk. So humidity is a critical factor. Now, despite what we know about physical characteristics, and our knowledge base is growing dramatically as our work and that of others is advancing some important findings on the effects of these different individual factors, we still see today that there's this attempt to try to estimate the heat exposure somebody's experiencing by using very basic temperatures that we see, the outdoor temperatures, airport temperatures, mean, minimums, the heat index, apparent temperature. This is all good, but it does not characterize the indoor environment. And that's a limiting factor. Why is that important? Well, number one, if we don't classify the level of heat exposure that an individual is facing indoors, we'll never understand the risk that they may face. So what we saw from the coroner's report, and this again is what Dr. Henderson was talking about, the number of deaths during the BC heat dome, and what we saw 619 deaths, and here's the death count, and here's the outdoor temperatures. Now, what's important is that 98% of these individuals who died were indoors, and 56% roughly were isolated. What's important, however, while they've given us maximum outdoor temperatures, we really don't know what was going on inside. What were they doing? Were they active? Was the indoor temperature a lot warmer than it was outdoor? And it's not impossible, and I'm going to show you some data on that. So what we do know is when we look at the internal environment, it's really dependent on a number of factors. If we just focus on the home itself, the construction type, whether it's brick, whether it's made of concrete, whether it's aluminum siding or vinyl siding, then we also have windows. Are they large windows? Are they westerly facing? Are they operable? Temperature control, what kind of ventilation system do you have? Is there ventilation in the attic? That would certainly reduce the amount of heat stored within or heat gained within the home. And then there's a number of occupants, as I've indicated. People don't think about that. We're generating a lot of heat. If I have 5 people, if you've ever been in a meeting, you know it gets hot after about an hour when you have 100 people in a big room. Then there's location. Am I in the urban jungle where there's a lot of concrete pavement where that's going to radiate a lot of heat? It's going to absorb heat during the day. It's going to radiate that heat back to that home. So that's an important factor that we need to consider. So when we look at what is happening indoor, I think this is kind of an interesting study that was published in 2020 and 2012, and it assessed indoor temperatures in a number of homes in the Detroit, Michigan area. And it is the temperature range that, again, they're not far from Toronto, so we can get a sense that it's pretty close to some of the temperatures we experience here. And they assessed it in homes of the elderly. And what we do see is they assessed it in 2 key periods at the end of June, at the start of August. Now, I've identified 2 areas here, and I can see all these are part of the description of various types of homes. And here's 2 homes, single family, small homes, just 700, 900 square feet. And both of them had air conditioning. Now, for that same day, for that same level of that same outdoor temperature, one home was 27.5 degrees peak and the other was 35. These are dramatically different temperatures indoor. Yet, if I use that outdoor temperature as my indicator, I certainly would underestimate the risk that that person would face indoor. Clearly, an 8-degree difference has an important effect. All right, another point that we need to remember. When does that heat event occur? Important for a number of reasons, because again, the human system can adapt over the summer. There is some level of adaptation. When it comes early on in the summer, like what we saw in the Western Heat Dome in mid to late June. What we do know, in this case here is a study in Greece. I certainly know it's warmer in Greece, but that's not the point. The point here is Greece has moderate temperatures in June, around the mid-20s. Here we had an early heat wave. And you can see at the very bottom in June, the outdoor temperature during that 5-day heat wave peak was 41.5. Indoor temperature increased to 34.1. Now later on, the temperatures moderated, got a little cooler, sort of back to normal. Then they had another in July, another longer heat wave, albeit the intensity was less at 39.9 degrees Celsius, but room to indoor temperature increased ever so gradually. So we know that over the summer, the building builds up heat, it gets warmer. And that becomes obviously difficult to control if you have no adequate ventilation. And then you saw this reprieve in late August. So in this case, there was slight increase in temperature, but the peak was only 37.8, and there was actually a decrease in indoor temperature when usually August is the hottest part. So what's key here is the timing and that duration of the heat event is critical, because that can have an effect on the individual when it comes to that level of exposure. Now, despite everything that we keep talking about, the importance of indoor temperature, there's so few epidemiological studies that have examined the health effects of exposure to heat, and that limits our ability to really define safe indoor temperature limits, and certainly how best to adapt to these. But let's take a look at one study that essentially tried to characterize this response. And this is a recent study that was published in 2020, and they essentially looked at heat-related deaths in the Houston, Texas area. Obviously, a lot different from our environment. And they looked at mortality and emergency hospital data, and they compared that with some of the indoor temperatures that they modeled. And the indoor temperature, again, this is not direct measurement, so it's just they used a model in which they used building energy models, they also used outdoor weather data, and they also used building characteristic data. But ultimately, they showed what we already know, is that older adults are at risk. Those people living alone at greater risk of a heat-related hospitalization or a heat-related injury. So this is important, but it still doesn't go to the root here of understanding what are the physiological response so that we can help mitigate that effect. So therein lies perhaps a critical knowledge gap towards really defining what that safe indoor temperature limit should be. So let's take a look at what we did to try to at least address one of these critical knowledge gaps. So what you see from the work that we started in 2019 is looking at different indoor temperatures. Now, we are particularly interested about 26 degrees Celsius because Toronto Public Health a number of years ago recommended that perhaps this indoor temperature limits should be 26 degrees Celsius. And it was based on the idea that essentially, when they looked at daily mortality, it increased by about 3%. With a 5% increase in daily mean temperatures. And this was based off of the 2010 heat wave in Ontario and Quebec. So based on sort of what they saw as the average mean temperature in Toronto, which was around 21 degrees Celsius, if they maintained indoor temperature at 26 or below, that would limit any potential excess mortality when temperatures got a little warmer. Now, interestingly, the National Health Services in the UK also recommends that indoor temperature should not exceed 26 degrees Celsius. Similarly, the New York City's Office of Emergency Management recommended a same upper limit. So obviously there is some general understanding that this may be beneficial, but we need to look at the evidence. So one of the things that Dr. Henderson showed was this figure here, and I think it's rather interesting because, again, as she indicated, when you have an air conditioning, you're about 22 degrees Celsius, which was one of the low ends of the temperatures that we assessed. And we also know that in the absence of having air conditioning, certainly air temperatures will fluctuate. Again, in this case here during the heat wave, and you can see ranging from 25 to 40 degrees Celsius. So what we decided to do in the study is look at a day-long heat exposure in elderly adults. We had them at 22 degrees, one trial at 22, next one 26, 31, and 36 degrees Celsius. At the 26 degrees, again, that's the indoor temperature limit. 31 would be a typical hot summer day in Ontario, Quebec, but it also represents the temperature just under 32 degrees, which was the indoor temperature limit recommended by the World Health Organization, just removed recently in 2021. 36 represents some of the highest indoor temperatures that were measured in Detroit, around that temperature, and obviously some of the higher temperatures. But we see from the BC heat dome here that essentially temperatures can certainly reach much higher than that. All right, let's take a look at the evidence. So what do we see in terms of changes? So you're looking at here the time-dependent changes during this day-long exposure in elderly adults. Now, I want to note that the responses that you're seeing here are similar to what we saw similar findings in our patients with well-controlled uncomplicated type 2 diabetes and hypertension. So, but I'm just going to focus today on this elderly group. So what you see then, if we look at the change over the 8 hours, you see a marginal increase in temperature at the 22, a slightly greater increase at 26 degrees, and certainly much higher levels. So as the temperature got higher, it really pushed that person to try to increase their heat loss. It took them time, as you can see. Heat balance was not achieved until late. So the body's working really hard to try to dissipate that heat. So we got to think that's a stressor. Just because, again, core temperature is stable doesn't mean they're out of the woods. The body is under strain. Where's the evidence for that? Let's take a look. So if we look at the next slide here, we're looking at the cardiovascular response. I can't show you all the physiological systems in today's presentation, but let's focus on the common one that we pretty well know a lot about, and that's heart rate and mean arterial pressure. So what we're looking at here is over time, we see the changes in heart rate, but if we focus just on the relative change over that 8 hours, you can see there's a minor increase in heart rate at the 26 degrees Celsius, and certainly at the 31 and 36, there's a marked increase in heart rate response. In parallel, what we see is a drop in blood pressure. So what does that mean? That means when you go in a warm environment, one of the things that happens is there's what's called skin vasodilation. You are now perfusing that skin with this warm blood, so you can transfer that heat to the skin surface. In doing so, you're opening up all this vasculature, 100 miles of vasculature that needs to be perfused with blood. The heart has to work much harder, has to pump harder to try and maintain blood flow through the heart and through all the other organs. But in this case, it wasn't enough to protect against a reduction in blood pressure. So what happens? These older adults here, if we look at these as individuals, think about them as possible people that were in that Western heat dome, they may have collapsed during that heat event, perhaps fall, going from sitting to rise, any kind of maneuver that would affect blood pressure regulation. And that's like walking up the stairs as another example that could have caused them to pass out. All right, so what are the take-home messages? And Dr. Henderson certainly overviewed them nicely. So what we can say is a single day exposure to temperatures of less than 26 will likely not create undue physiological strain in older adults. So we can say that safely. Now, sustained exposures, temperatures greater than 26, but around 31 or less will certainly still pose a risk to health. And that's something we need to be concerned about as well. But over 31 degrees, I definitely would not recommend that an older person, a vulnerable person, be exposed to those conditions. Now, what's missing in this whole thing? Well, we've not looked at the effect over successive days. And why is that important? Because that stress level remains fixed over successive days. And as Dr. Henderson's figure demonstrated, temperatures can be maintained for prolonged periods. And why is that important? Well, here's a study that was done in Netherlands, exact same temperatures that you see in BC. So over the summer it gets warmer, but you can see that outdoor temperatures gets warmer and warmer, and you can see that indoor it's getting hotter and the bedroom gets hotter. In parallel, some of these heat-related symptoms or stress, so symptoms associated with heat-related stress, you can see they're rising. So the health and well-being of a person can be affected even at 26, meaning that it can still be a stress. Now, that's not to say that 26 is bad. It just means that we also have to consider that it can be stressful and it can cause sleep disturbance. It can exacerbate somebody's pre-existing health condition. So it's just a factor that we will need to consider. Now, finishing off, one thing we have to ask ourselves at the end of the day is, listen, if my home is overheated, what can I do? Obviously, there's options. We can go to a cooling center. So if you have a loved one in an overheated home, what can you do? You can bring him to a cooling center. Question is, does that work? Well, we expose these older adults to a day-long heat exposure at 40 degrees Celsius. We have the red, no cooling, and the blue is those individuals that were put into the cooling center. What you see is, again, a slight reprieve, a drop in core temperature over that 2-hour period. However, what I do need you to note, it rebounded very quickly. Within the first 2 hours, they're back to the same level of hyperthermia as they were before they got in. What about that blood pressure, the burden on the heart, how hard the heart has to work? And you can see before, blood pressure is down, and after, it's also down and remains down. So they're still under stress, even though they've been to the cooling center. So while it does provide a temporary reprieve, we have to remember that we need to continue protecting them upon reentry to the home. And that may mean using other heat mitigation. Is it fans? Rob will answer that question in a few minutes. So I give credit also to the National Collaborating Center for Environmental Health, because they're also looking at options to reducing overheating in your home, to give guidance to families on how best to do this. And there's simple solutions, even if it's just putting cardboard over your window, or perhaps thinking about over the long term, planting a tree to reduce the heat load on the house. Those are important changes that we have to make. So I finish off. Thank you very much for your attention. I'll leave it to Rob now to continue with the presentation.
All right, awesome. Thanks so much, Glenn. Everyone can see my slides. All right, excellent. So yeah, today I'm excited to present some work we've been conducting evaluating the effectiveness of fans as a personal cooling intervention. Now, the title of the talk kind of gives away our conclusions, but I'm really excited to show you how we got there over the next 15 minutes or so. And I did my best to kind of avoid a real technical discussion, but I do think discussing the technicalities is important because they help us understand why a given cooling intervention may or may not be effective in certain conditions. Now, what do we mean by a personal cooling intervention? Based on the World Health Organization's guidelines, we might consider an effective cooling intervention any strategy that can be implemented at the individual level that helps a person maintain their core temperature within a healthy range. So before we can suggest the use of any strategy in guidance documents or policy, there are really two important things we need to figure out. First, is it going to be effective for reducing core temperature? And second, is it going to be easily implementable for the most vulnerable individuals? Now, when we think about staying cool during heat waves, the first thing that pops into most people's heads is air conditioning. And this is for a good reason. There is considerable evidence that air conditioning is effective for protecting people. Take the data shown on the right-hand side, which is from a meta-analysis of case control studies by Boucham et al. Owning a working air conditioner was shown to reduce the odds of heat-related death in older adults during heat waves by about 77%. And as Glenn kind of discussed in the last presentation, even temporarily visiting a cooled location is associated with a pretty stark reduction in heat-related mortality. So I think we can all agree that air conditioning represents a highly effective means of protection from extreme heat. However, where AC becomes a bit tricky is on the implementation side. They're expensive and not financially viable for many of the most vulnerable individuals. And they can also contribute to greenhouse gas emissions and therefore play a role in exacerbating planetary warming. Now, for this reason, there have been increasing calls for the use of sustainable, low-cost cooling interventions for protecting people, their wallets, and the planet. And perhaps the most widely discussed of these interventions is the use of electric fans. I'm going to hold off for a few minutes about talking about the epidemiological data, but currently the guidance documents send kind of mixed messages on whether fans are effective. So for example, the Government of Canada website on heat waves and health says if you have ceiling fans or other fans, they can help as long as humidity isn't high. And similarly, the WHO's guidance documents on heat health warning systems stipulates if air temperature is higher than 35 degrees, the hot air passing over the skin can make an individual hotter. Generally, the use of fans should be discouraged unless they are bringing in significantly cooler air. And in fact, we often see this kind of similar messaging that fans are recommended up until about 35 degrees Celsius, after which point they're discouraged. And this is where things get a bit technical, but just to summarize very, very briefly, 35 degrees Celsius is the approximate temperature of fully vasodilated skin and the theoretical ambient temperature where increasing airflow over the skin is going to actually cause the body to gain heat more rapidly. However, what's not often considered in these documents is that even in conditions in which fans cause you to increase heat gain, they may still facilitate the evaporation of sweat, which is the most powerful route of heat dissipation in humans. So when we think about whether fans are effective for personal cooling, what we need to be concerned with is how they influence the balance between dry heat gain and sweat evaporation. And this idea was actually recently explored in a biophysical modeling study by Morris et al. And what they did was use standard equations to model heat exchange in hypothetical young and older adults resting with and without a fan in a large range of ambient conditions as summarized in the figure here on the left. So to determine the conditions in which fans should be used, they compared the fan-induced increase in dry heat gain with its effects on the evaporative potential for heat dissipation, which you can kind of think about as the rate of evaporation possible when sweating is at its physiological maximum. Now, in conditions where the fan-induced increase in heat gain outweighed the increase in the potential for evaporation, fans were deemed detrimental and the authors cautioned against their use. And these conditions are shown in the figure as those above the red line for healthy young adults, so young adults without any chronic health conditions that might affect heat vulnerability, and above the yellow line for healthy older adults. Now, by contrast, in conditions where the fan-induced increase in evaporative potential outweighed the increase in dry heat gain, fans were considered beneficial and recommended for use. And these conditions are simply those below the lines in the figure on the left-hand side. So based on this study, the authors proposed in a 2021 series on heat and health published in The Lancet that public health policy documents should adopt new limits for safe and effective fan use of 39 degrees Celsius for young adults and 38 degrees Celsius for older adults, which, as you can see, is quite a large increase from the documents we were talking about earlier that's already published by health agencies. However, one thing you might have noticed is that in the study by Morris et al., they didn't actually evaluate the effect of fans on core temperature. And I'm not going to get into the technical aspects here, but an improvement in the evaporative potential for heat dissipation, which is more or less an environment level variable, does not actually guarantee a meaningful reduction in core temperature at the person level. And to us, this was a major shortcoming, giving WHO's guidance that a personal cooling intervention should be able to do just that, help individuals effectively manage their core temperature. So for this reason, we conducted a sort of critical or analytical review of existing evidence on the effectiveness of fans for reducing core temperature in hot weather. Now, our primary analysis was a biophysical modeling study. So first, we simply modeled heat exchange in healthy young and older adults with the same approach used by Morris et al. And then we extended the model using some calorimetry data from our laboratory to estimate the influence of fans on core temperature. We also performed a sensitivity analysis where we evaluated the robustness of our findings, and I'll cover that in some more detail in a few slides. And then finally, in secondary analyses, we compared our inferences from the primary analysis to findings from an additional biophysical modeling study, laboratory-based heat exposure studies, as well as the epidemiological data on fan use. Now, in all of our analyses, except for the epidemiological data, we quantified the effectiveness of fans in two ways. Now, in the first way, we evaluated whether the predicted reduction in core temperature with fan use exceeded 0.3 degrees Celsius, which reflects the clinically significant difference proposed in a laboratory study based by Morris et al. So this, what we basically considered was 0.3 degrees was the minimum fan-induced reduction in core temperature that we would want to see if we're going to recommend fans for protecting people. Anything less, we might consider negligible or trivial. Now, in addition, technical difficulties. There we go. In addition, we also evaluated the effectiveness of fans relative to direct cooling, sufficient to maintain a thermo-neutral ambient environment, which could be achieved, for example, with central air conditioning. So to make these concepts a little clearer, on the right-hand side here, I've shown the predicted increase in core temperature with and without a fan in young and older adults resting in 34 degrees Celsius and 50% relative humidity, which is similar to recent heat waves we've had here in Ottawa. So in the older adult, we can see that fan use is expected to reduce core temperature by about 0.3 degrees Celsius. So we might consider its usage beneficial in an absolute sense. However, we can also see that it's only about 30% as effective as air conditioning. If this hypothetical person had not been exposed to the heat at all, a 1.0 degree increase in core temperature would have been prevented. So without further ado, let's get into the results. So the figure here is a heat map of the expected increase in core temperature without fan use in individuals resting in ambient temperatures ranging from 30 to 44 degrees Celsius on the y-axis and 10 to 90% relative humidity on the x-axis. The panel on the left shows model predictions for a hypothetical young adult, while the panel on the right is predictions for an older adult. And in both models, we can see that as ambient temperature and humidity increase, core temperature is elevated. And by comparing the two models, we see that in a given condition, there's a greater increase in core temperature in the older adult, since the model accounts for age-related changes in thermoregulatory function, as Dr. Kenny discussed. In fact, even in temperatures below about 40 degrees Celsius, we can see that the expected increase in core temperature in the older adult will be about a degree to a degree and a half, which may place them at risk of heat-related illness and injury if sustained over prolonged periods. And the next two panels here, we have the predicted change in core temperature with fan use, again, with the young adult on the left-hand side and the older adult on the right. So basically, this figure shows how much core temperature would be expected to change from the previous panels if we gave the hypothetical subjects a fan. Now, in these figures, we can see that fans are expected to reduce core temperature in both young and older adults in ambient temperatures as high as around 39 or 40 degrees Celsius. However, the reduction in core temperature with fan use only met our threshold for benefit at ambient temperatures below 33 degrees Celsius in the young adults and 34 degrees Celsius in the older adults. Above these temperatures, the fan-induced reduction in core temperature is negligible or trivial until about 40 to 42 degrees, at which point fans became detrimental. Next, let's take a look at how fans stacked up against air conditioning. Now, the panels here show the fan-induced reduction in core temperature as a percentage of the increase in core temperature that would have been prevented if the person remained in an air-conditioned environment. And here we can see that at ambient temperatures at or above around 35 degrees Celsius, fans are no more than 30% as effective as air conditioning in the young adult and only 23% as effective as air conditioning in the older adult. But even at temperatures below 35, you can see the performance of fans relative to AC isn't particularly great, especially for the older subject. Now, switching gears for a moment, one thing that hasn't been highlighted in previous work is that biophysical modeling requires that we make multiple assumptions for key physiological and physical factors in order to estimate heat exchange. So to evaluate the robustness of our model to variations in these assumptions, we performed a sensitivity analysis where we made slight alterations to key model inputs to see how it impacted the predicted effectiveness of fans. These assumptions included model inputs for mean skin temperature, minimum sweating efficiency, thermosensitivity, fan and age-related alterations in skin wettedness, maximal sweat rate, and how convection was modeled. And I'm not going to get into how these different variables factor into the calculation of core temperature, but all possible permutations we tested produced a total of 2,160 models, reasonable estimates of the influence of fans on core temperature. So in the top figure here, I've shown the distribution of model predictions for the young and the older adults combined. On the x-axis, we have ambient temperature, and on the y-axis, we have the fan-induced change in core temperature with humidity shown in the colors. We can see that consistent with our previous slides, as ambient temperatures increase past the historical limits to shut off a fan at 35 degrees Celsius, we see most models do not predict a meaningful cooling effect, as signified by the area above the green line. Now, looking at this slightly differently, in the bottom panels here, I've shown the full distribution of model predictions for a select few conditions. Again, the young adults are on the left and the older adults are on the right. And here we can see again, most models don't support fans as beneficial, especially as ambient temperature increases. But another important takeaway here is that the way we model thermoregulatory function can have pretty drastic impacts on the predicted effectiveness of fans. And moving forward, we need to carefully consider this uncertainty when we think about using modeling studies to inform heat health policy and guidance. So that was our primary analysis, but as I mentioned, we also looked at some additional evidence sources to see how they lined up with our findings. The first study we included in secondary analysis was a modeling report by Tartarini et al., who used a slightly different model called Gaggy's model to evaluate the effectiveness of fans. And this model actually allows for core temperatures to be modeled directly. So in this case, we simply extracted and reconstructed the core temperature data from their article, which is shown here on the left-hand side. The no fan conditions are shown in the orange and salmon, and the fan conditions are in the blue and the purple. And again, we can see that core temperature increases with ambient temperature and humidity, but the lines for the fan and the no fan conditions appear quite close. So to look at this a little bit easier, in the next panel here, I've calculated the cooling effect of the fan by subtracting core temperature in the no fan model from that in the fan model, as shown in the blue and the purple. And I've also depicted the cooling effect of air conditioning, again, which is simply just the increase in core temperature that would have been prevented if an individual had not been exposed to the heat at all, and that's shown in the green and yellow. Now, consistent with our primary analysis, we see that fans are not predicted to elicit a meaningful reduction in core temperature under any of the modeled conditions. But by contrast, maintaining a thermoneutral ambient environment is quite effective for cooling, especially as ambient temperature and humidity increase. Now, in our second secondary analysis, we extracted data from laboratory-based heat exposure studies on fan use. So in these, actual individuals are brought into the laboratory and exposed to simulated heat wave conditions for up to 2 hours typically, with and without a fan, and then core temperatures are measured and compared. Now, there's a lot of information presented here, so I want to direct your attention to two main things. In the blue, I've highlighted all the studies that employed experimental conditions in which fans would be considered beneficial under the new recommendations published in the Lancet. And these show that while fans did cool the body, the cooling effect was never more than about 0.1 degrees Celsius, and fans were never more than 25% as effective as air conditioning. Now, these studies were only performed in young adults, so I want to highlight the two studies that did include older participants. And we can see here that as with the young adults, in no instances have fans been shown to be effective for core cooling in this age group. Now, the employed conditions here are quite hot and actually above what's recommended in the Lancet. So this doesn't actually rule out the possibility that fans might be effective in older adults at lower temperatures. But at this time, we don't have any empirical support for the idea that fans can be used to protect the elderly during heat waves. All right, so to summarize the key takeaways. First, the preponderance of evidence from biophysical modeling and laboratory-based heat exposure studies does not support fans as an effective personal cooling intervention, especially as ambient temperatures exceed around 35 degrees Celsius. And this finding is largely consistent with existing epidemiological data showing that owning a working fan was not associated with a statistically significant reduction in heat-related mortality in older adults during heat waves. We also discussed that moving forward, we need to consider the uncertainty arising from modeling assumptions when we use biophysical modeling to estimate the effectiveness of really any cooling intervention. And then finally, our analyses also suggest that direct cooling with air conditioning is the most effective protection from extreme heat, even in conditions where fan use is beneficial. Now, I know we're running out of time, but I do want to quickly add one caveat that in the long term, it's not going to be sustainable to rely solely on air conditioning for our cooling needs, because as I mentioned at the start of the presentation, air conditioning can be cost prohibitive and environmentally damaging. Now, with improvements in cooling technology and the transition to greener energy alternatives, we'll hopefully see just a kind of natural reduction in the economic and environmental burdens of air conditioning. But there is also the opportunity to combine air conditioning usage with more sustainable strategies to lower the requirement for direct cooling. So for example, as Dr. Kenny talked about in the last presentation, building level interventions like external shading or reflective roofs or green architecture can be used to reduce the buildup of heat within a house or residence during the day. And these can be probably combined with increased use of person level strategies like fans, which may be used to cool the body at lower ambient temperatures, meaning we don't have to make our homes quite so cold. But the key here is that while we can't abandon air conditioning altogether, we need to start thinking about strategies to reduce our reliance on it. And I do really think this sort of holistic solution is going to give us the best chance to protect the most vulnerable persons from extreme heat and climate change, while also limiting further damage to the planet. But that's the end of my talk, and thank you all for having me. I'm happy now to take any questions.